Hello everyone, today we will discuss about renal cancers. Most renal cell cancers are incidentally detected while doing imaging diagnostics and they account to 90% of all renal tumors with an incidence of 2 to 5% in adult males and 1 to 3% in women. The clinical classic triad presentation in less than 5% of cases is that of flank pain, hematuria, and palpable mass. Most common symptom is hematuria. IVC involvement warning signs: bilateral lower limb edema, right side non-reducing varicocele, paraneoplastic syndromes noted in up to one third of the patients. There is increased ESR, which is most common, hypertension, anemia, hypercalcemia, Stauffer syndrome, which is reversible hepatitis without liver mets, polycythemia, cannonball mets of lung, and brain mets. Major acquired risk factors are cigarette smoking, obesity, hypertension, diuretics, occupational exposure to petrochemicals and dyes, acquired renal cystic disease on long term hemodialysis. Clear cell carcinomas are most commonly associated with von Hippel-Lindau syndrome and is autosomal dominant disease. The genetic trigger is loss of chromosome 3p and mutation in VHL gene. The other associated symptoms are the retinal angiomas, hemangioblastomas of brainstem, cerebellum, spinal cord, along with pheochromocytomas. Other genotypes linked are the in papillary renal cell carcinoma, we note chromosome 7, 17 or Y aberrations. Molecular pathogenesis of clear cell carcinoma. Step 1. Genetic aberration. Loss or mutation of the VHL tumor suppressor gene, which is located on chromosome 3p. Step 2 is pathway disruption. Loss of VHL prevents the degradation of hypoxic inducible factors. Step 3. Angiogenic overdrive. It leads to massive overproduction of vascular endothelial growth factor. Step 4 is phenotype. It results in hypervascular, lipid-rich phenotype characteristics of clear cell carcinoma. This exact vascular endothelial growth factor pathway is the primary target for tyrosine kinase inhibitors used in advanced systemic disease. Biochemical investigations to be done. CBC. If HB is low, then even hematuria is assessed for. Calcium is a prognostic factor. More than 10 grams per dl suggests poor prognosis. Creatine or RFT is assessed as a baseline function for pre-nephrectomy patients. LFT and LDH. Elevated ALP suggests bone mets. LDH is useful for risk stratification. Radiological imaging, CECT of abdomen and pelvis with contrast enhancement of more than 15 household is significant. CT thorax or chest X-ray for lung mets of cannonball, bone mets, bone scan is done at along with ALP elevation or bone pain. MRI brain if patient is symptomatic of headache or seizures, etc. MR venogram if IVC thrombus is suspected. Biopsy is not routinely done for any renal mass. Cystic mass evaluation as per Bosniak classification. Category 1 simple cysts, 0% risk of malignancy. Category 2 or 2F intermediate or minimally complex. Category 3 intermediate cystic mass often treated as RCC. Category 4 cysts with enhancing solid elements, 70% risk of malignancy, definitely treated as renal cell carcinoma. As per histopathology, renal cancers can be classified into 5 main groups: clear cell, papillary, chromophobe, collecting duct carcinoma, and renal medullary carcinomas. The first one, the clear cell renal cell carcinoma, is the most common and accounts to 85% of cases. It originates at the proximal tubular epithelium. It is sporadic or familial in origin and is associated with VHL mutation as discussed earlier with loss of chromosome 3p. It varies by nuclear grading. Papillary renal cell carcinoma has two subtypes, type 1 and 2, and is the second most common type. It is multifocal or bilateral. Chromosome 7, 17 or Y aberrations are noted. Type 1 has better prognosis than type 2. Chromophobe renal cell carcinoma accounts to 1 to 2% cases. Solid sheets of large cells are noted. It is usually sporadic and has good prognosis. Collecting duct carcinomas 1 to 2% arises centrally in renal medulla. It is an aggressive form. Renal medullary carcinoma less than 0.5% arises centrally in renal medulla. Unique association with younger age and sickle cell trait. Very aggressive. Grading standard by WHO or International Society of Urological Pathology system. Furman also used and presence of sarcomatoid features suggest worst prognosis. As per the site of origin, when renal cell cancer arises from the collecting system, they are the upper tract urothelial carcinomas. From renal parenchyma of benign origin are the oncocytoma, angiomyolipoma, juxtaglomerular cell tumors. From renal parenchyma and malignant forms are the clear cell, papillary, chromophobe, collecting duct, and medullary. And the pediatric or the embryonic renal cancer is named as Wilms tumor. Renal cancer is also known as incidentaloma, internist tumor. Renal cell cancer TNM staging system. Stage 1 or T1 is confined to kidney. T1A is less than 4 centimeters. T1B is more than 4 or equal to or less than 7. Stage 2 or T2 is confined to kidney but is a large mass. T2A is less than or equal to 10 centimeters. T2B is more than 10 centimeters. Stage 3 or T3 has the vascular or perinephroic invasion. T3A extends into renal veins or perirenal fat. T3B extends into vena cava below diaphragm. T3C extends into vena cava above the diaphragm. T4 or the stage 4 is beyond gyrotous fascia. It invades beyond the gyrotous fascia, including the adrenal gland. Renal cell cancers are confirmed on imaging. Localized are T1, T2. Locally advanced are T3, T4, IVC, thrombus. Metastasis, any TM1 stage. The localized are treated by nephron sparing and advanced stages are treated with nephron sparing versus radical surgery as per the renal score and surgical risk, and vascular reconstruction driven by the myothrombus levels, and metastatic diseases are treated by systemic and cytoreductive driven by the IMDC risk stratification. RCC treatment is strictly algorithmic intervention and is dictated not by the tumor subtype but by anatomical boundaries breached, that is gyrotous fascia, venous involvement, and metastatic spread. Management of localized RCC and small renal masses. Assess tumor stage and location. Also analyze renal score for tumors less than 7 centimeters. Active surveillance is done for small masses less than 2 centimeters size, elderly patients, high surgical risk. Rationale is slow growth of approximately 0.5 centimeters per year with very low metastasis risk. Imaging every 6 to 12 months. Thermal ablation criteria is T1A masses less than 3 centimeters in high risk patients. Radiofrequency or cryoablation is to be done. Nephron sparing surgery, partial nephrectomy criteria. The gold standard for localized T1A less than 4 centimeters and selected T1B 4 to 7 centimeters tumors and bilateral tumors or pre-existing renal dysfunction. For tumors more than 7 centimeters, that is T2, radical nephrectomy is planned. Criteria: large multifocal tumors where partial nephrectomy is not feasible. Removal of entire kidney within gyrotous fascia. Ipsilateral adrenal gland is spared unless CT or MRI shows involvement. Less than 10% rate. Coming to renal score, R stands for radius. 1 point for less than or equal to 4 centimeters, 2 points for more than or equal to 7 centimeters, 3 points for more than or equal to 7 centimeters. E is exophytic or endophytic. More than or equal to 50% exophytic carries 1 point. Less than 50% exophytic carries 2 points. Entirely endophytic carries 3 points. N is for nearest sinus or collecting system. More than or equal to 7 mm, 1 point. More than 4 to less than 7 mm, 2 points. Less than or equal to 4 mm is 3 points. A is anterior or posterior. It is denoted by suffixes A, P, X and H. L is location, polar lines. 1 point for entirely above or below. 2 points for crosses polar line. 3 points for more than or equal to 15% between polar lines. Score ranges from 4 to 12. Higher score, higher surgical complexity. Location often dispatches partial or radical nephrectomy feasibility more than pure size. Steps in partial nephrectomy technique. Cool kidney with ice. It increases ischemic time tolerance. Mobilize entire kidney. Clamp artery and vein. Remove tumor with distinct margin. Suture kidney or oppose Gerota's fascia. B. Radical nephrectomy principles. Entire kidney enclosed in Gerota's fascia is removed. Crucial step, renal artery ligation must occur before renal vein ligation to prevent dangerous swelling. Adrenalectomy only if adrenal is involved and it happens in less than 10% cases. Lymphadenectomy only for high risk patients with large tumors and enlarged nodes. This is called the Blut criteria. Ablative method done are the cryoablation and radiofrequency ablation. The indications are high surgical risk, solitary kidney, hereditary multifocal lesions, local recurrence after partial nephrectomy. Progression-free survival similar to partial nephrectomy. Local recurrence higher than partial nephrectomy, 3 to 20% often salvaged with repeat ablation. Complication lower than partial nephrectomy. Hemorrhage is most common. Post-operative renal function comparable or better than partial nephrectomy. What's the post-ablation imaging protocol to be done? First done at 6 to 12 weeks. The first post-ablation CT or MRI. Complete loss of contrast enhancements suggests success of the treatment. Persistence of enhancement suggests incomplete or need for repeat ablation. Then at 3 to 6 months, second scan is done. Lesion enlargement suggests local recurrence. Then for 5 years, the scans are repeated annually and continued surveillance is done. Routine post-ablative biopsy is not recommended unless recurrence is suspected radiologically. The cryoablation, it works on the Joule-Thomson principle. The mechanism is organ gas causes rapid expansion, which leads to slow freezing away from the probe, creates extracellular ice crystals. This leads to dehydration or membrane rupture. Thawing leads to cellular edema and death. Target temperature is minus 40 degrees centigrade. Cancer death at minus 50 degrees centigrade. Dynamics is that ice wall should be 5 to 10 mm larger than the target. Double freeze thaw cycle, 8 to 10 minutes freeze, active helium thaw. Radiofrequency ablation, the molecular friction technique. Mechanism is monopolar AC current 450 to 1200 kHz is passed. Ion vibration within the tissue occurs. Molecular friction generates heat and heat is not supplied directly. The heat causes cell damage. The targeted temperature is 90 to 105 degrees centigrade. Dynamics, dry versus wet radiofrequency ablation, highly susceptible to heat sink effect. Nearby large vessels draw away heat, reducing efficacy. This is the drawback. Advanced renal cell carcinomas have vascular involvement. In level 0, which happens in 65% of cases, the Thrombus is confined to renal veins. In level 1, 10% cases, the thrombus is within 2 centimeters of renal vein of the renal vein ostium. Level 2, 15% of cases below hepatic vein. Level 3, 5% between hepatic vein and diaphragm. Level 5, 5% extension above the right atrium. IVC thrombus occurs in 5% of cases of renal cell carcinomas, and 45 to 75% are fused with an aggressive surgical effort. Intraoperative transesophageal echocardiography is vital to check for the expansion of thrombus into right atrium. The bland thrombus Mayo groups Group A to D range from no bland thrombus to mixed or infrarenal requiring direct resection. A is thrombus in ipsilateral renal vein, B is infrahepatic renal vein, C is retrohepatic or subhepatic, D is contralateral renal vein and or iliac venous system. The treatment options for vascular involved RCCs level 0 and 1 with low complexity, radical nephrectomy plus IVC milking, partial IVC occlusion and ostial cavotomy using a Satinsky clamp is done. Must preserve more than or equal to 50% of the IVC diameter. Level 2, complete IVC mobilization or control intrahepatic cavotomy is done. Sequential clamping rule, caudal IVC, contralateral renal vasculature, cephalad IVC. Level 3 requires suprahepatic IVC clamping, may require veno-venous bypass plus infrahepatic cavotomy. Level 4, the highest complexity, requires cardiopulmonary bypass with deep hypothermic circulatory arrest and infrahepatic cavotomy and right atriotomy. For the bland thrombus, type B, at or below iliacus, IVC filters are applied. Type C, infrarenal, separate from the tumor, vena caval clip is placed. Type D, mixed with tumor, resection is done. Resection of a completely occluded IVC may not be needed to establish collateral circulation. Renal cell carcinoma metastasis. Once metastasis is confirmed, it is checked whether the metastasis is resectable or not. If resectable, radical nephrectomy with metastasectomy is done. Else, the Carmina study is considered and IMDC favorable risk criteria is calculated, and if it fits the criteria, the cytoreductive nephrectomy is done followed by systemic therapy. If not, then the Carmina trial proved no outcome of difference from cytoreductive nephrectomy is non-favorable conditions. Systemic therapy alone with sunitinib or ICI is given. Palliative surgery indications are severe pain from primary persistent hematuria, colic, SRBT recommended for brain and bone mets. IMDC risk stratification, International Metastatic Renal Cell Carcinoma Database Consortium. The risk factor checklist consists of Karnoscope performance of less than 8, time from diagnosis to treatment of less than 12 months, anemia, hypercalcemia, elevated neutrophils, and elevated platelets. Favorable risk when 0 risk factors present, intermediate risk when 2 risk factors present, poor risk when more than 2 risk factors present. Pediatric manifestation of RCC is Wilms tumor or nephroblastoma. The embryonic mass, the Wilms tumor, stretches the renal parenchyma and gives the claw sign. You can see in the image the claw sign, how it appears. A large central embryonic mass distorts and stretches normal renal tissue around its periphery, creating a characteristic crescent or claw appearance. Coming to demographics, it is the most common renal tumor of childhood, 5% of all childhood cancers. Peak incidence is during 1 to 4 years.
It is bilateral in 5%. Pathology, it is mixed embryonic nephrogenic tissue. Blastemal, epithelial, and stromal elements are noted. Presentation, large palpable abdominal mass in an otherwise healthy child is noted. It may cross the midline. Pain is uncommon unless ruptured, associated with hematuria and hypertension. Diagnosis and management. Ultrasound confirms the origin. CECT or MRI is done for staging. CT chest is required to look for lung metastasis. Most common treatment is nephrectomy with pre or postoperative chemotherapy. It has excellent prognosis with 90% survival. Urothelial cancers of the kidney. The diagnostic markers are the CTU, radiolucent filling defects, incomplete calyx visualization can be noted in CT urogram, flexible ureterorhinoscopy, enhanced by narrowband imaging or blue light. It is rare and is less than 10% of the urothelial tumors. The risk factors are tobacco, petrochemical dyes, cyclophosphamide, high arsenic dyes, similar to the bladder carcinoma. The pathology, the thinner muscular layer leads to aggressive invasion. Follow up, multifocal nature requires long term bladder cystoscopy. UTUC is confirmed, then risk stratification is done. Low risk is localized invasion. Endoscopic ablation or segmental excision can be done. Kidney sparing surgeries imperative for solitary kidney or insufficiency. In high risk cases, radical nephrourectomy plus bladder cuff resection with or without lymphadenectomy is carried out. In locally advanced cases, cisplatin based neoadjuvant chemo followed by surgical ablation is done. The most common benign tumors of kidney are the renal oncocytoma, angiomyolipoma, and juxtaglomerular cell tumor. Renal oncocytoma, the key features are 5% of renal tumors, eosinophilic cytoplasm, and imaging. There is central stellate scarring, spoke wheel, angiographic appearance. The management is partial nephrectomy, very difficult to differentiate from chromophobe RCC. Angiomyolipoma, there is fat, dysmorphic vessels, smooth muscle noted, associated with tuberous sclerosis. In pregnancy, it has high bleed risk. CT intralesional fat density of 15 to 20 Horsfield is noted, which is pathognomic. Ultrasound bright echogenic mass can be noted. Less than 4 centimeters surveillance is carried on. Acute bleeding, angioembolization is done. mTOR inhibitor for tuberous sclerosis associated lesions can be administered. Juxtaglomerular cell tumors, extremely rare, noted in young age. It has a triad of hypertension, hypokalemia, and high renin. Imaging, it's not much features of diagnosis are noted. Management is surgery, is curative, and hypertension resolves after surgery. Systemic therapies involve the tyrosine kinase inhibitors, sunitinib, sorafenib, pazopanib, axitinib. The mechanism of action is they inhibit vascular endothelial growth factors. Immunotherapy (RCC) is highly immunogenic. The checkpoint inhibitors are the nivolumab, atezolizumab. mTOR inhibitors are the everolimus, sirolimus. Adjuvant therapy trials. General rule, there is no role for adjuvant therapy in non-metastatic RCC. S-TRACK trial, sunitinib versus placebo, improved DFS, but no OS benefit not routinely practiced. Assure trials, sunitinib or sorafenib versus placebo. There is no DFS or OS benefit. Atlas, axitinib versus placebo. No DFS or OS benefit. Protect study. Pazopanib versus placebo. No DFS or OS benefit. Here, DFS is the disease-free survival. OS is the overall survival. Thank you.